Okay, folks, I've just hit the record button, so I think we might as well start. So first of all, hello everyone and good evening, and thank you all very much for joining us. You're all very welcome to this webinar, which is organised and hosted by the Irish CFS Association. My name is John Cullinan. I'm a senior lecturer in economics at NUI Galway, and I'm also a member of EuroMean, which stands for the European ME Network. And together with Orla Nicori from the Irish CFS Association, we're going to present this evening on our study and our research on the economic impact of CFS in Ireland. So thanks to the Irish CFS Association for organising. So I just want to start and give you a quick outline of the talk and the plan of action in terms of how it's all going to work and the timelines involved. So I'm going to start off and I'm going to give you a brief introduction to CFS for those who are not familiar. And then I'm going to talk a little bit about our research partnership between me, the academic researcher, and then the Irish CFS Association, because I think it's quite unique, you know, the nature of this research project, given the central role that ME patients have had in terms of the entire research project. So I want to talk a little bit about that. I also want to talk a little bit about what economic costs are and why they're important to measure, and you know what exactly an economist means by an economic cost. And once I've done that, then I'm going to talk a little bit more specifically about the research that we conducted. And once I get through that, basically then what I'm going to do is I'm going to hand over to Orla, and Orla is going to go through in quite a bit of detail what we found in the study. She's going to talk about the results of our research, and then she's going to hand back to me after that, and I'm going to finish up with some concluding remarks and some thoughts, both about the study, but also about where the study fits into maybe the wider picture. And overall, what I expect is that this is going to take, between Orla and I presenting, it's going to take around 35 to maybe 40 minutes in total in terms of the presentation. And the plan then is for us to take a 5-minute recess before starting the Q&A session. And what I'm going to basically propose is that we all take a little breather during that 5-minute break, that you think about what questions that you might want to ask, and you'll have a couple of options. You can type your questions into the chat function in Zoom. That usually works quite well. Or we'll also have, you know, if you prefer to ask it by turning on your microphone and your camera, and that's absolutely fine as well. So as I said, this is being recorded, so just as a reminder to you all, if you are asking questions or making comments, this is going to be recorded. What I would ask you to do is, just for the purposes of the presentation, when Orla and myself are speaking, is that you turn off your microphones. It might make sense to turn off cameras as well. I'll leave that up to you. We don't mind at all, but certainly turn off your microphone while we're speaking, just to avoid any feedback or any extra noise on the recordings, if you don't mind. So that's the plan of action, folks. And so what I want to do now is, and I do appreciate that many of you are going to be very familiar with some of this material that I'm just going to start off with. You'll know quite a lot, if not more, about ME than I might, but there may be some people in the room, virtual room, who are not familiar with ME or not very familiar with ME. So I just want to give a little bit of background and context to the illness. So first thing to state is that ME stands for myalgic encephalomyelitis. I hope I got that right. It's also known, or commonly known, or at least referred to, as CFS, or chronic fatigue syndrome. Now, there is some debate and some disagreement around the terminology, but we're not going to focus on that. I'm just going to talk about ME or ME-CFS. I'm not going to get into the terminology. But basically, ME is a chronic and complex neurological illness, and it's characterized by a range of different symptoms. And some of these symptoms include things like cognitive dysfunction, orthostatic intolerance, unrefreshing sleep, and there's a bunch of other symptoms. But probably the most important and defining symptom of ME is something called post-exertional neuroimmune exhaustion, or it's also called post-exertional malaise. And this is basically, in really simple terms, this is a worsening of symptoms, of ME symptoms, after even sort of very mild physical or even mental exertion. And this is a really important part of ME and is an important element in terms of what sorts of treatments are, might be recommended for ME. Other things that are important to note about ME include the fact that ME mostly affects adults. Onset is usually in early adulthood. It can affect children, so children can develop ME, but it mostly affects adults and young adults, but it's much more common in women than in men. So around 80% of people with ME are female. And one of the really big challenges with ME, as I see it and many others see it, is that, routine diagnostic tests and indeed biomarkers for the illness or the condition are not available. And that's a real challenge, both from a health economics perspective, but also obviously from a medical perspective. And then another really important challenge associated with ME from a patient perspective is that there's pretty broad agreement that ME is generally not well understood by a lot of medical professionals. Now, this is not all medical professionals, obviously, but at a general level, there's a lot of evidence to suggest that medical professionals don't know a whole lot about ME. Many haven't been taught about it in medical school, for example. And because of these different challenges, the challenges in relation to a diagnostic test being not available, a lack of understanding about the condition, what this basically means is that a lot of patients end up facing considerable difficulties getting an early or an appropriate diagnosis. Sometimes they're misdiagnosed. Getting appropriate treatments can be a real problem in lots of cases. And then also accessing the appropriate services and supports that ME patients require can also be challenging. Another really important point to make right at the outset of the presentation here is that while there isn't a sort of a widespread understanding in the general public around ME, that's not to say that ME is a rare condition. ME is actually quite a common condition. There are an estimated 10,000 to maybe 19,000 people living with ME in Ireland, for example. Now, we don't have an exact number on this, and those estimates are derived basically based on prevalence studies or prevalence estimates from other countries. But it is important to realize that this is not a rare illness. This is relatively common. And it's also important to note that ME can be a really, really serious illness. So it can have quite a profound and serious impact on those who are affected, both in a medical sense, but also, in terms of an individual's health, but also in terms of their personal circumstances. So not for everybody, but for some people, ME can end up being a career-ending and even a life-destroying disability. So what happens for some people where the prognosis is really bad, or where they develop severe ME, is that it can really impair people's ability to function on a regular basis, both cognitively and physically. And if it develops to a severe or a very severe stage, patients can end up housebound or bedbound, for large portions of their life, or even for the rest of their life. So it's a really, really serious condition, and it's not uncommon. And both of those factors, I think, make it very, very surprising, at least to me, and also very, very disappointing that there's actually very little research on ME in the Irish context. So if you think about it, this is an illness or a condition that's relatively common and has major negative impacts on individuals across a range of dimensions, yet there's very, very little research and very little research funding available on the illness in the Irish context. So in the area that I work in, I'm an economist, there's been absolutely nothing done in Ireland looking at the economic impact of ME. And that's in contrast to other disease or other illnesses where there's a huge amount of research, there's a huge amount of research funding available, say, in relation to those conditions. ME really stands out in that regard to me as an economics researcher. Something else that I think is important here, particularly for what this research is about is that there's quite a long history of ME patients being ignored or excluded from research, and even in some research studies and by some researchers been vilified. And I think this is really important because when Orla and I initially started talking about doing research or doing some work on the economic impact of ME, you know, we both agreed right at the outset that it was important that ME patients be centrally involved in whatever research was done. And we were then fortunate that, you know, given what we were hoping to do, that an opportunity arose through the Community Engaged Scholars Programme at NUI Galway, the CESP at NUI Galway, for us to form, Orla and I, and then and Tom also, to form what's called a community academic partnership. So the idea of this program was the program would give a small research grant, some small funding to develop a partnership that included both a patient organization, for example, from the community side, but then also some academic researchers, and that you know, they would work together, the community partner and the academic partner, in order to do something that benefits patients. And what Orla and I did, and along with Tom, was we developed a proposal, and that proposal was we wanted to develop a collaborative patient-driven research agenda and approach to examine the economic impact of ME. So I'm an economist, and my interests here and my expertise, you know, is on the economic side. And what we wanted to do, or what at least I wanted to do along with Orla and Tom, was for, you know, us all to work together so that we could better understand the economic impact of ME. Because as I said, there's been nothing done in the Irish context in relation to that. So here's a photo of part of the research team. So Leanne, I promised you there'd be a nice photograph of you. So that's me on the left, Orla in the middle, and Leanne Black, who's on the right. Leanne joined us. She was a student at NUI Galway at the time of the study, and she joined the research team initially as a researcher and then was formally employed as a research assistant on the project. So we were the sort of the core researchers, along with Tom Kinlan, who was also working with us. And here you can see us, we're all smiling in this photograph, because you can clearly see that this must have been at the outset of the project. We hadn't realized at this stage how much work was actually going to be involved in doing all of the focus groups and all of the analysis. So we're all in good spirits. That's the first thing to note. The other thing to note here is just the labels behind us. So it was funded through the Community Engaged Scholars Programme. This programme is run by a group called PPI Ignite. And PPI stands for Public and Patient Involvement in research. And the PPI Ignite team at NUI Galway are funded by the Health Research Board. So I just want to acknowledge both the HRB and PPI Ignite for funding this research, because it wouldn't have happened without them. Okay, so what I want to do next is, just for a few minutes, I'm not going to bore you all with too much economics here. I appreciate it's not everyone's cup of tea. But what I do want to give you a sense of is when we talk about economic costs, or when economists talk about costs, I want to give you a sense as to what it is we're interested in estimating or modeling. And I think probably the best way to describe that, because it informs what we've done in our research, is to give you a sense of the two main types of quantitative studies that examine the economic impact of an illness like ME. So the two main types of studies, quantitative studies, are cost of illness studies and individual level studies. So if I just start off and maybe mention what a cost of illness study is. A cost of illness study looks to try and identify, first of all, and then measure or quantify the variety of different direct and indirect costs of an illness, and then estimate the overall economic impact on society. So the idea is that you would try and say, for a particular illness, what are the direct costs associated with that illness? So those sorts of direct costs might be something like, say, the out-of-pocket expenses, health expenditures that a patient might make because of their illness. So you pay money to go and see a consultant, it costs 200 euros. That's a direct out-of-pocket expense for you. But there would also be direct expenses to the state or to the health service where individuals with ME are receiving health services, for example. So these are all typical direct costs, and you would look to try and quantify them. But there are also really, really important indirect costs or indirect economic costs of an illness. So for example, if you get sick with ME and you're no longer able to work, well, then there's going to be a loss of income to you, and there's going to be a loss of productivity to the economy. So if you're not working, you're not producing goods and services. This is classical sort of economic activity, and that's a really important indirect economic cost of an illness like ME. And there can also be other indirect costs, like, you know, the cost of informal care provision, for example. And the challenge as an economist is you've got to, number one, identify all these different costs, and then you've got to value them in some way, aggregate them, and you come up with a number then at the end which says, you know, the economic cost of ME to society is X hundred million euros per annum. And that's a very typical kind of sort of economic or health economic quantitative analysis of the economic impact of an illness. And then somewhat relatedly, there are what are called individual level studies. And the focus here is, instead of sort of the aggregate economy or the aggregate impact of an illness, what you try and do is look at how it impacts individual patients or their carers. So we might be interested in understanding a person who suffers from ME, how much more likely are they to be unemployed, or how much more likely are they to be living in poverty or have a low standard of living, and so on and so forth. Now, what I'd say is, regardless of the type of quantitative study that an economist is doing, it is increasingly important, and it is now acknowledged as being increasingly important, to incorporate the patient perspective in whatever study you're doing. So before you go and you cost things and you add up all those costs, you need to talk to patients and get to understand, well, what are those costs? So you identify the costs first of all through talking to the patients, and then you come up with a way of measuring those costs. Excuse me. So there's different ways in which you can do that, okay? And one way, and I think a very, very good way of doing that, is by using what are called qualitative research methods. And essentially that's what we've done in the paper that we've just published and what we're going to be talking about today. We've talked to patients and we've used these qualitative research methods in order to understand what cost patients are facing and their carers. And the next phases of our research are going to be then using what we've learned from this research in order to do the types of quantitative studies that I've mentioned here, the cost of illness study or the individual level study. So all of that's going to follow at a later date. Next thing I just want to mention here as well, before I go on and talk about what we did specifically, is one of the things that became really clear to us, and we hope that this will continue into the future, but it became very clear to us that ME patients in Ireland are very keen to engage with researchers. So, for example, one of our participants in the study said to us, she said, "My husband said to me, 'What the hell are you doing this for today like?'" And the reason the husband said this was he probably understood the toll that participating in a focus group was going to have for the ME patient. There was going to be a knock-on effect for that person the next day or the day after. And her response was, "I feel like I have to say something, because nobody is listening. You're just invisible. So this is our opportunity to just say it." And basically the point here is that this is really about hearing the patient voice in ME research before the economist or before the academic goes off and crunches the numbers. You want to get the patient involvement and the patient perspective in terms of what's important to do and even how you go about doing that research. And I think that was something we were able to do quite well in this study. And in terms of the study and the research that we did, we basically undertook 3 focus groups. A focus group is simply a meeting of a small group of people where you discuss in a sort of semi-structured way a variety of questions in relation to the broad topic, like what costs do you face? So we held 3 focus groups with ME patients and carers in late 2019. We had a focus group in Galway with 9 participants, in Dublin with 5, and in Cork with 7 individuals. Orla, Leanne and myself ran those. And I think it's really important here just to note that the focus groups were jointly developed, organized, and delivered by patients in conjunction with researchers. So it was very much patient-driven at all levels of the research. And the other thing that was done by patients and researchers together was something called the thematic analysis. So once you hold these focus groups and you talk to the patients and you talk to the carers, you basically record those conversations and transcribe them. And then using a qualitative research methodology called thematic analysis, you try and identify different themes and sub-themes that relate to the central research question, which was the economic cost of ME, and try and understand and represent the themes that are most important to patients and carers in terms of the costs. So we've done all that and we've concluded our study essentially. We've now published our paper. This is what the front cover looks like. It's published in the journal HRB Open Research. We deliberately chose an open access journal because for some journals, you have to pay to access the research, believe it or not. So we picked one that's freely accessible to the public. So if you go to the journal HRB Open Research, or if you Google the title of this paper, you'll be able to download a copy of it and read it if you want to learn a bit more about it. The paper itself has been viewed over 800 times already. It's just been published a couple of months ago, but it's already been viewed 800 times. So we're very encouraged by that, and we'd encourage you to check it out. And just to acknowledge, the co-authors on the paper. So Orla, who's going to speak in a moment, Tom Kindlin, who many of you will know, Leanne, who I mentioned earlier, but also Blauheen Casey from the University of Limerick. She was drafted into the research team to help us with some of the qualitative research methodology. So that's it from me for the moment, folks. What I'm going to do is I'm just going to stop sharing for now, and I'm going to hand over to Orla, and Orla is going to share her screen. Take your time, Orla. There's no rush. And once she does that, she's going to now take you through basically the main findings and the main results from the study. So I'm just going to hand over now to Orla, and you can take it away from there.
Okay. All right. I'm going to talk a bit about the results that we found based on the focus groups now. So you can see from this slide that we grouped the findings into themes and sub-themes. And I'm going to look at the healthcare barriers and costs first, because that was kind of in some ways the most important one, in terms of some of that would have implications for some of the other costs. For example, if delayed diagnosis or poor advice resulted in worsening of condition. So like I said, I'm going to look at healthcare barriers first, and we split this into a few different sub-themes. So the first one was getting a diagnosis, or difficulty getting a diagnosis. And so this was, unfortunately, it was a common problem. For some patients, it took years with numerous visits to GPs, consultants, and other healthcare professionals for the illness to be identified or even acknowledged. So some healthcare professionals wouldn't provide a diagnosis. In some cases, this stemmed from disbelief about the condition, but in others, it was more lack of understanding and awareness of the condition. So in many cases, this lack of awareness and understanding led to significant costs for patients due to having to attend multiple doctors for answers. And this is an example from a patient of one of the experiences and one of the problems. And this is a comment from a carer whose adult child had a diagnosis from a consultant in another country. And she said, despite me saying to him, well, you know, the World Health Organization have recognized this as a disease. Are you telling me that you don't believe it exists? And he said, that's the GP. Yes, I don't believe. He said, with your son, I'd like to start again. So he's on the waiting list for an Irish diagnosis. And it can be particularly difficult for children to get a diagnosis or understanding. So one care participant mentioned that neither of her two children, who both got sick when they were aged 12, could get a diagnosis until they turned 18. And sometimes children were just not believed about what they were going through, which obviously caused a lot of stress for them. I got a virus when I was 16, and it took 2 years before a locum GP diagnosed me as chronic fatigue syndrome, ME. But at that time, my GP just kept telling my parents that I was lazy, looking for attention. She's the oldest of 4. She's looking for attention, and that's all it is. Ignore her. So even after diagnosis, there were problems for patients getting access to professionals with an understanding of the condition. So this resulted in time and financial costs as patients looked for medical professionals who knew something about the condition. So as an example of the type of expense incurred, one person mentioned going to a consultant rather than a GP as a regular doctor because the consultant was understanding. And this is how she explained it. It's not an option for me to move to a GP and pay the lower rate because they're just not out there that they understand what you're going through. So another cost was inappropriate psychiatric referrals or treatments, which meant taking up a scarce resource as well. One person who got diagnosed by an immunologist, but they referred her to a psychiatrist. And she says about this, even my psychiatrist that I went to, he even said to me, they're telling me it's your body that's letting you down, but they send you to a head shrink. He said to me, it's contradictory. And I said, well, I know. That's the patient talking there. Sometimes the patient or family would be given poor advice, which risks making the condition worse, leading to greater long-term costs. So this is just an example. I have had a lifetime of there's nothing we can do. Psych are just like going, oh yeah, you need a course of CBT and you need to get exercising and you need to want to live life. The newest thing I've got from psych here is he told my family I just didn't want to be involved in life and that until I decided I wanted to live, just leave me in the corner and for everyone else to go on with their life. So young people seem to be particularly vulnerable in regard to misdiagnosis and misunderstandings about the condition, leading to increased costs. And this is an example from a carer. And she said, but the cost was very much emotional as well as monetary because they tried to convince me that my children were depressed, that they had mental health issues. I had to pay to have them seen by a psychologist privately to prove that they weren't. And I had to refuse CAMS from even coming to the house because I was afraid they were going to take my second kid away. So because of poor understanding, patients sometimes end up not mentioning the ME's CFS when they see consultants or other doctors that are not their regular doctor. In case of a negative attitude, in some cases, patients avoided going to the doctor, which is risky in terms of overall health if other health problems are missed. And this is how one patient explains the problem. Then there's trips to the GP, which I don't do very often because she's so dismissive. So another sub-theme under healthcare costs was tests and treatment costs. So a lot of patients paid out of pocket for private tests and treatment. And a lot of patients would try, for example, alternative treatments, partly due to lack of other options. And one patient put it like this: when you go for a diagnosis, first you meet the doctor who either doesn't know anything about it or who doesn't want to know. So you go and try other treatments. And then there can be a significant ongoing cost with some treatments. And as one patient put it, you're going every single week for months or years, and all you're doing is managing. You're never extinguishing the fire. You're just keeping it a little bit tame. So another cost under healthcare costs was travel costs. And patients often traveled for diagnosis, tests and treatment. And this was to find doctors who knew something about the condition. So costs included direct transport costs and often overnight accommodation, as some patients were not able to make the return journey in one day. So a carer might also be required to travel with the sick person, adding to the cost, both in terms of direct travel costs and if the carer had to take time off work to accompany them. So I'm going to move on now to the next major theme, which was socioeconomic costs. So the first sub-theme here was the impact on employment and earnings, and this will be very familiar to many of you. So for many patient participants, ME CFS had a major impact on their careers, often with devastating implications for their current and future employment prospects, as well as for their earnings. Even when they couldn't work, it was often, even when they could work, it was often for a limited amount of time, and some of them could only do it because they were working from home. So reduced earnings were very considerable for some, and this is an example from one of the participants of the focus groups. Loss of income is phenomenal. I've lost an annual income of around about 100,000 a year. I haven't been able to return to my job for several years now. I tried to reduce my hours. I tried to work part-time, eventually had to give up. So financially, the implication is huge. As well as the devastating impact on individuals' own personal socioeconomic circumstances, participants also mentioned the economic losses to wider society arising from ME CFS. One example was regarding the tax on income that they were not now paying due to having give up work. And it was also noted by a number of participants that the benefits of their education and training would not now be realized either for themselves or by society. And this is how one patient put it. Yeah, it's massive in terms of the 8 years it took for my training to become professionally qualified. in terms of the investment from the state into my training. So the standard of living was the next sub-theme under socioeconomic costs, and the reduced earnings obviously had an impact on the current standard of living. And this is an example. I have over the years had to make choices between whether I get oil for my house or whether I get a treatment. And there have been times I've picked the treatment, and I'm sure I'm not alone in that. I'm stuck in a cycle of debt, so I feel like kind of trapped in so many ways financially. And patients' potential future financial well-being was also affected. For example, when people used up savings, pension contributions, they had to retire on reduced pensions. And one patient, for example, mentioned having to retire on a half a pension. So another socioeconomic impact was on education, and this affected children and young people in particular. And this unfortunately could affect their future career options and earning potential. Some had difficulty accessing home education help, and schools were not always understanding about the condition. The illness affected ability to do exams and limited options for third level education as well. Some couldn't go on to third level, and even those that did had limitations or problems, even when they got accommodations. So I'm going to move on to the next theme, which was cost of disability. So this theme relates to costs incurred by patients with ME CFS that are related to the disabling nature of the condition and their need for services and supports due to it. So again, these costs are generally higher the more severe and debilitating the illness. So one of these costs were for things like home adaptations, aids and appliances. So one example of a home adaptation would be putting in a downstairs bathroom, and a few people in the focus groups mentioned having to do that. Another example is the cost of aids and appliances. And sometimes some of these were covered by the HSE, and sometimes participants had to pay for them out of their own pocket, for example, a mobility scooter. And then another cost, disability cost, was extra costs of living. So some of these would be everyday costs, but they're increased due to having ME, such as heating costs, which are increased due to poor circulation and also being at home more, childcare costs because people need extra help, cleaning and so on. And sometimes people paid for home visits from medical professionals, such as a dentist. And another sub-theme under disability costs was lack of services and supports. Difficulties accessing basic care services were described by a few patients, along with the costs this brought and the negative impact it had on quality of life. And this is one example regarding trying to access either home help or personal assistance help. And she said, a lot of people can't actually access any help from the HSE. So if you need any help, you have to hire them yourself. Yeah, I've been turned down for a PA and for home help because the home help saying I should be getting a PA and PA say I should be getting home help. So other areas people had difficulty in regard to accessing help was accessing social welfare payments or getting suitable housing. And this is an example from one carer parent mentioning, when I contacted the local council and told them of my inability to find suitable housing, they referred me to the local homeless shelter, that's where I should live. And she was the carer of two people with ME. So participants described the considerable efforts they had to go to in order to explain what ME CFS was to receive supports and services. So this was an extra burden due to the lack of understanding of ME CFS. So this is how one patient put it. You shouldn't have to prove that CFS or ME exists. We shouldn't have to go through all of these hoops. And now our last major theme was carer-related costs. And this theme related to costs incurred by informal carers and family members of patients with ME CFS. And these costs are not just financial in nature, but also include impacts on carers' day-to-day lives, their psychological well-being, as well as socioeconomic outcomes. So the first sub-theme here was time costs, and both carer and patient participants of the focus groups described the often very long hours spent caring for a person with ME CFS, particularly those most severely impacted by the illness. And this is an example. So it's been 24/7 for 12 years until X, that's a friend, persuaded me to take a break in September. So I took my first few nights away in 12 years. So that shows how restricted the person is. And carers could be restricted, very restricted in their day-to-day life due to their caring role. And this is another example. I prepare her breakfast and do lunch, leave it there. And sometimes I would come home from work and give her lunch. If I go anywhere, I have to be back in the evening. I can't stay out overnight anywhere. So another cost for carers was mental health and burnout. And some of the stress was from the general disbelief around ME CFS and the need to constantly fight for recognition of the condition. And as one parent said, I would think the cost of mental health would be huge in trying to constantly fight for them and fight for their rights and never giving up on them. It's a huge cost to on my health too. So other issues mentioned, including feeling alone and trying to deal with the illness and the frustration of not being able to fix the problem due to the lack of treatment options. So the caring role also affected work and study opportunities of carers. Some carers ended up having to take time off work. Some took early retirement or to care for sick family members or couldn't go back to work when they had intended to. One had to give up on a course she wanted to do. And one patient participant mentioned that her husband had to take on a second job to try to keep up with the mortgage payments with all the pressure, of course, that would cause him. So I'm just going to finish up now, and this is just an overview of some of the issues that we covered in the paper, and if people want more detail, they can go and have a look at the paper and just read up a bit more about that. So I'm going to hand you back to John now, who's going to talk about the significance of some of the findings and plans for future research. Thanks a million.
Thanks, Orla. I'm just going to get you to stop sharing your screen, if that's okay.
Yeah, thanks. I think I've done it now.
Thanks, Emil, and we'll go back to sharing my screen. So yeah, thanks again, Orla. That was a really great overview and summary of, I think some of the most important findings. And what I'm going to do now is I'm just going to finish up with some concluding remarks, and then we'll have a little pause, and then we can start the Q&A. The first point I want to make here is just, at an overall level, I think what the focus groups suggest to us is that, and this is important for our future research, is that ME patients face a really wide range of often very significant costs. So there are lots of different types of costs, and some of those in certain instances can be really significant. There are also, and again, this is important for future research, wider societal costs, and these come in a variety of different forms. So there can be costs to the health service, there can be costs in terms of lost productivity, and pretty serious impacts on informal carers in lots of different circumstances. So as I said, our next stage is, now that we've identified the range of costs and the different types of costs, what we'll look to do in the next phases of our research is actually to put monetary values on those costs and estimate them. One of the things, though, that I think is really useful from the research that we've done, and something that really stands out to me as an economist who works across a number of different, say, illness and disease areas, relates to the findings in the research that show that a lot of patients were talking about delays getting a diagnosis, or there was a lot of evidence in relation to poor awareness or understanding of the condition by healthcare professionals, and a lot of participants talked about a lack of effective treatments. And the reason that this is important and interesting in an economics context is that all of these different factors are generally linked, regardless of the area, but particularly for ME, they're generally linked to a poor prognosis. Basically, a prognosis is the likely course that a medical condition takes. And, all of these factors are likely to lead to, I suppose, worse outcomes for a patient as they progress through their illness. And the reason that's so important is that, with poorer prognosis and with worse health outcomes for individual patients, are inevitably going to come higher costs, okay? Because the sicker an individual is, and the more severe an individual's ME is, for example, well, the more care they're going to require, the less likely they are to be able to work full-time, for example, or the more likely they are going to have to retire early. So, in very simple terms, a failure to diagnose and a failure to appropriately treat ME, especially at the early stages, is likely to lead to, significantly increased costs. And that's a really important finding from the study. And that's relevant also if you think about the age profile of many ME patients, or the onset of ME for many ME patients. And, you know, onset for a lot of people with ME happens in maybe, you know, late teenage years, early 20s, early 30s. And these are years where ordinarily people are quite economically productive and they can look forward to maybe 20, 30, 40 years of productive work in the labor force, for example, or in a work environment. And if you get sick early in your life and the prognosis is bad and you fail to recover, well, obviously that's, you know, that's awful for the individual, but from an economic perspective, that leads to extremely large economic costs, because you could have 20 or 30 years of lost productivity for an individual who would ordinarily or otherwise have worked their entire adult life. So, you know, the relationship between a poor prognosis and the factors that I've been talking about earlier and the large economic costs associated with ME is really, really important. And I think now we've documented evidence in relation to that. The other thing I'd mention here is that, you know, to a certain extent, I guess a lot of people in the room today will be sort of familiar with some of these. Maybe many of you will have known this and it might not come as new to you, but at least now we have some of that evidence in the Irish context. And that evidence is also consistent with evidence from other international studies. So what this international evidence suggests is that the societal cost of ME CFS can be substantial. So these sorts of cost of illness studies have been conducted in other countries, and we want to do something similar for Ireland. But if I just give you a couple of numbers from other countries, from, you know, other good studies done in other countries, it'll give you a sense of the nature, the scale of these overall societal costs. So, for example, there was a study published recently from Australia, and it estimated that the societal cost of ME in 2017 in Australia was 14.5 billion Australian dollars per annum. So that's an astronomical number. There's another estimate, I think, from a pretty good study from the UK, which estimated that the societal cost of ME in the United Kingdom in 2014 was 3.3 billion pounds. Now, you have to be very careful if you extrapolate from countries from studies from other countries, which are very different contexts, you know, to say another country like Ireland. But if you were to do some sort of back of the envelope calculations and take the results from those studies from Australia and the UK and adjust for population size and maybe some prevalence rate changes and currency differences, etc., very simple back of the envelope calculations would suggest that in Ireland, the societal cost of ME could be anywhere between €250 million right up to over €1 billion per annum in Ireland. Now, these are rough estimates based on a lot of assumptions and studies from other countries. So these are not the sorts of estimates that I'd hang my hat on. But what it gives you a sense of is, look, these are astronomical numbers. These are really, really large societal costs. And the challenge for Orla and Tom and myself going forward is to try and refine those estimates for Ireland based on the results from the study we've been talking about today. Another point that I want to make, which I think is really important in relation to what came out of this study is, and this might be surprising to non-economists, but there are good costs and bad costs. And the way I look at a lot of the costs associated with ME in the Irish context is a lot of these costs are bad costs. And what I mean by that is, you could imagine a situation where ME patients in Ireland you could at least hope for a situation in Ireland where ME patients, when they get sick, receive an early diagnosis, get good treatment and services and supports, and the expenditures on those services and supports and treatments actually have a positive benefit on the individual and help maybe make them better, or at least help them have a better quality of life. And any costs associated with those services and supports could be considered good costs because they're expenditures that are actually having a positive impact on the health and well-being of a sick individual or a sick population of individuals. But one of the things I've noted about the research that we've conducted is that actually in the Irish context, a lot of the expenditures in the health service, both from the individual's perspective, the costs that they're making, moving from consultant to consultant to consultant, or from the health sector's perspective where, you know, people are being given seeing the wrong consultants, a lot of these expenditures or costs are actually bad costs. They're inefficient allocations of resources because people with ME are not getting the right services and supports that they actually need. And what we need really is a reorientation of, you know, the contacts that people are having in a lot of situations, so that actually people are getting treatments and services that are, you know, associated with good expenditures that actually have a positive benefit. So I think that's something that will, you know, that's an important point to make, and certainly something we'll be looking at in future research. And then another point, or a final point here, is also worth making in the context of thinking about larger sort of economy-wide or societal costs of ME, and that's the relationship between long COVID and ME. So, you know, we're still relatively early in terms of the COVID-19 pandemic, in terms of our understanding of its impact on long COVID and how long COVID is going to play out. But increasingly, there's quite a lot of evidence to suggest that at least some portion or some people who are suffering from long COVID have symptoms that are very, very similar to ME CFS. And the idea here basically is, because onset of ME is often post-viral, and obviously COVID-19, you know, is related to the coronavirus, you know, there is emerging evidence, and indeed a lot of people, you know, beginning to suspect that what we're going to see post COVID-19 is large increases in the prevalence of ME. And if that's the case, what that means is that the economic costs or the societal costs of ME are going to go up fairly significantly as well. So I think that's important to note here, that we're likely looking at an increase in ME related costs. So that's all the sort of the problems that we've sort of identified, if you like. What about potential solutions? What is it that we can do about this? And unfortunately, you know, there's no real easy answer to this. This is a sort of a tricky enough question, but usually when you're doing research as an economist on a particular disease area or an illness, and you're thinking about maybe interventions that might help to reduce economic costs, what you do is you look at various potential types of interventions. So you look at interventions related to prevention strategies, for example, or interventions that might help find a cure for a condition, or interventions that improve health and social care services to, you know, improve the quality of life of patients. And unfortunately, when it comes to prevention and also to cure, because we know so little about ME, unfortunately, we don't have a whole lot of guidance there in terms of, you know, what should we do on the prevention side or the cure side to reduce, you know, the problems associated with ME and the economic costs. So really what that means is sort of the focus has to sort of narrow in terms of the care provided to ME patients. And what I'd say in relation to provision of care services, both health and social care services, is based on the work that I've done with EuroMe, the European ME network, one of the key things we need to do is to really dramatically improve the knowledge and understanding of ME amongst healthcare professionals. It's absolutely a paramount, because that will help us to reduce time to diagnosis, you know, targeting more appropriate treatments, getting away from those inappropriate treatments that many ME patients end up having, but just basically getting better medical care. And what I don't want here is just to point the finger at our doctors and consultants and, you know, do, you know, finger pointing or you know, engage in a blame game, because in many cases, our doctors and healthcare professionals are, you know, they're pretty unaware of a lot of the issues around ME. And one of the reasons for that is they're not taught it in medical schools, for example. So a lot of doctors have just not learned about ME in medical schools. So I think the importance and role of medical schools, but also the medical representative bodies in terms of continuing further education for our healthcare professionals is really important, because ultimately what we want to have is, you know, better services and supports for patients. And that will come through a better, or in part at least, through better knowledge and understanding amongst our healthcare professionals. So that's one thing we can do. But I also think what we need is a sort of a unified health system response that really comes from the top down as well. So, you know, a lot of patients that I've spoken to have talked about the lack of a care pathway, say, for example, in relation to ME, that, you know, they go to a doctor or they go to a consultant, and there's no clear pathway in terms of their treatments and managing their condition. And I think that certainly needs to be improved. One negative side of it, though, however, is that if you think about maybe a sort of a top-down led approach whereby, you know, someone, you know, like the HSE, for example, or the Department of Health, you know, takes the lead in terms of developing these pathways and developing, you know, greater understanding. It's not really encouraging in terms of where we are at the moment in terms of the HSE's engagement with ME and indeed our health service more generally. So I did this a couple of weeks ago for another exercise. I went to the HSE's website and I went to their Health Finder, and basically what I did was I typed in their search tab here, I searched for myalgic encephalomyelitis, and then I didn't find anything, so no results came up. So I thought, okay, maybe they have it in under ME. So I typed in ME and I found nothing there. So then I typed in chronic fatigue syndrome, no results. CFS, no results. So the point I'm trying to make here is that the agency, the health service executive, the agency that's charged with running our health service, doesn't even acknowledge the existence of this illness on its website. So this is an illness maybe 10, 20,000 people in Ireland live with. And if you go looking for information on it on the HSE's website, you find nothing, you know, and that I think is really, really disappointing. It's quite dispiriting. So I would say we really need a fundamental change right from the top down in terms of the healthcare services and supports that are available to ME patients. Now, what I don't want to do is finish on that awful negative note. So let me finish with something that's maybe slightly more positive. Clearly, there's a lot of work that has to be done in this area. And the good news is, and I've seen a lot of evidence of this with my work with Euromean, is that there is a pretty substantial, at least relative to sort of 10 years ago, a pretty substantial international scientific effort to find a biomarker for ME, to find a cure for ME. There are very, very good, high quality researchers across the United States, across Europe, across Australia, for example, serious researchers engaged in research, high quality research to try and develop a cure for ME and to develop our understanding around ME. And it's also possible, I think, that with the problems associated with long COVID, that more research funding is going to be given to this area. So I would be cautiously optimistic that in the future we will see some progress on this issue. So I wanted to finish on a slightly more optimistic note than the HSE slide. So hopefully that will give you a little bit of grounds for optimism. Okay, so that's it from me and for Orla for the time being. First of all, thank you all for